Hi, my name's Ewen Griffiths. I'm an upper GI consultant at the Queen Elizabeth Hospital in Birmingham, and it gives me great pleasure to present the impact of COVID-19 on our OG cancer service. Thanks for the privilege of talking to you all. This is the outline of my talk. I'll give you a bit of background on the Birmingham Cancer Unit. I'll talk about the Birmingham ICU response to COVID. And try and tell you how it's affected our OG cancer treatment and pathways, and try to end with a sort of future direction, really. The Queen Elizabeth Hospital is in Birmingham. We have a wide catchment area, and hospitals from Dudley, Walsall, Sandwell, City, Heartlands, Solihull and Good Hope refer into our centre for major OG resectional surgery. We cover quite a deprived population in the centre of Birmingham. And previous NOGCA results has put our unit in the top 4 or 5 for resectional numbers. And this is our unit's resectional numbers for the last 21 years. As you can see, with each successive hospital sending their resections to us, we've increased the numbers performed. Perhaps what's interesting this year is the numbers seems to have dipped, and we're uncertain whether that's related to advanced disease and problems with patients being diagnosed in a timely manner due to effects due to the COVID pandemic. And we're going to look at that in a bit more detail at a future date. One of the main reasons I came to Birmingham was it had the single largest critical care unit in Europe, with 100 bed spaces, with a mix of ITU and HDU beds. The big ICU is split into 4 areas, each catering for different specialities. Traditionally, Area D was cardiac and cardiac and lung transplant. C was neuro, B was trauma and burns, and Area A was the upper GI, HBB, liver transplant and general surgery. And these are the rates of COVID in Birmingham in all 3 waves of the COVID pandemic. And naturally, this had a massive effect on us here in Birmingham. In the first wave, this arose to various things that happened for the COVID response. There was lots and lots of staff redeployment and training. There was creation of intubation teams, which took our anaesthetists away. There was formation of tracheostomy teams by maxillofacial and ENT, and also line teams staffed by radiologists and renal physicians who were used to putting in lines. There was also proning teams to prone these often large patients, and the trust decided on an emergency rota, which was 4 days on, 4 days off. And this did affect me. I was sent to ICU for several weeks in the first wave to get some upskilling in critical care. Perhaps I was lucky, but my skills weren't required to be on the COVID ICU. And I developed a job plan doing emergency endoscopy and looking after our cancer patients. We didn't particularly operate in the first wave for about 5 or 6 weeks. And when we did, there was much excitement. Obviously, our ICU teams got very adept at treating COVID patients, and they developed a system which was published, having split the sort of care of these patients into small pods led by more junior leads, and then area leads, and then sector commanders were the sort of fully trained ICU consultants. And it obviously hit the hospital very hard, and you can see these press cuttings showing that at its peak it had over 125 patients intubated in ICU, and it had the capacity to double that due to the ICU doubling its beds and also going back into the old cardiac intensive care unit. And over 200 doctors were redeployed to ICU during the sort of worst times of the pandemic. And these are the results from critical care. There's a smaller ICU in Heartlands, but overall the two units treated 1,700 patients with COVID. Practically all of them were mechanically ventilated, as the sort of CPAP units were in different areas. And in the first wave, the COVID mortality was about 33 to 35%, reducing to 25% in the second wave. And the median ICU stay for a patient on COVID ICU was 20 days. And therefore, it was estimated that for every ventilated patient on COVID ICU, this cancelled between 20 to 35 patients requiring high-risk surgery. The 4-on, 4-off rota allowed plenty of time for me to engage in research, and I helped with the COVID surge cohort study and the COVID surge cancer project. And we also did our own survey using the oesophagogastric anastomosis network. And this ushered in lots of webinars, which I was involved in. And this is some snapshots from the sort of survey we carried out, which was international. There was obviously widespread effects of cancer staging tools. Things that were poorly available were things like endoscopic ultrasound and staging laparoscopy. But across the board, pretty much every pathway was affected. And the units involved changed their approaches in several patients to either definitive chemoradiotherapy or offering neoadjuvant treatment to earlier cancers, or extending the number of cycles of chemotherapy. And in the first wave, this affected us greatly because the routine diagnostic endoscopy largely stopped. The 2-week pathway largely moved to CT scanning. We stopped staging laparoscopy because of limited lists. And there was an extreme limit to ICU beds available for esophagectomy patients. Due to concerns of COVID spread, we abandoned our usual hybrid and MIO approaches. And the confusion around screening these patients led to us admitting patients a day before for CT thorax, which was then abandoned later on. And of course, there was no vaccinations. This just shows our surgical figures, the 18 months pre-COVID and the 18 months in the COVID era. The orange bar is the ICU cases with COVID. And as you can see, this did limit our surgical capacity. And when we did operate on the highest peaks, this was mainly due to ICU, lack of ICU, and we did gastrectomies that went back to the ward. We had to institute weekly prioritization meetings and have detailed information on patient comorbidities, disease stage, and whether they were suitable for alternative treatment options, and looked at their risk of delay. And it was very good to have the AUGIS guidance for treating these patients with esophageal and gastric cancer. and these were very helpful when they were sent out to us, because we allowed us to use this to frame what patients we'd operate on and how we'd prioritize them. But sadly, it's not over, and even in July, our hospital had to stop operating on all elective patients in July this year. And there's major concerns about the winter crisis, which is whether the NHS has sufficient capacity to operate on patients with cancer. The good news for us is that we developed an enhanced perioperative care unit staffed by recovery nurses to allow us to continue operating on cancers. And I think this is a great achievement. It allowed us to have gastrectomy patients having total gastrectomy to stay for 1 night, and selected fit esophagectomies for 2 nights, usually if they were having a hybrid approach with no epidural and were run off paravertebral blockades to limit the need for inotropic support. And there was an on-site consultant anaesthetist until midnight, and then overnight it was the theatre registrars manning the unit. But even today, there's real concern that our hospital is hanging on by a thread. And in conclusion, I'd like to say that the COVID pandemic has adversely affected all aspects of esophagogastric disease management. The long-term effects of the delays and the pathway alterations has yet to be realised. Winter is clearly coming, and we do need a global NHS approach to this crisis, and we perhaps need to be better prepared with regionally ring-fenced, secured cancer units being the ideal option. And I'd like to thank these people who helped with this talk, and thank everyone at the Queen Elizabeth Hospital who's worked tirelessly to treat our COVID and non-COVID patients alike. Thanks for having me. Thank you very much.